As we move forward from the 2024 election, the threats to our movement for racial justice and a multiracial democracy are clearer than ever. At Race Forward, we're working to dismantle the deep roots of structural racism and challenge dangerous, divisive narratives. And to do that, we need your support. Podcasts are one of the most powerful ways to share truthful information, elevate real stories, and build lasting connections. With your help, we can create more episodes with crucial conversations, uplifting the work being done in communities across the country to keep moving our work forward and spreading fact-based narratives that strengthen democracy. Support our work by texting RFPOD, that's RFPOD, to 44321. A donation of $24 in 2024 makes a real difference. Together, let's sustain these critical conversations and push for the change that we need. Welcome to Momentum, a Race Forward podcast. I'm Aletha, Manager of Podcast and Audio here at Race Forward. Today's episode features a compelling conversation between our host, Race Forward President Glenn Harris, and our esteemed guest, Dr. Aletha Maybank, Chief Health Equity Officer and Senior Vice President of the American Medical Association, AMA. The American Medical Association is the trailblazer sponsor of our upcoming Facing Race 2024 conference that is taking place next week in St. Louis, Missouri. As part of their commitment to advancing health equity through Rise to Health, a national coalition for equity in healthcare, the AMA will bring its National Health Equity Grand Round series to Facing Race. The National Health Equity Grand Rounds aims to deepen understanding of health inequities, shape national discourse, and outline strategies to improve the nation's health. The National Health Equity Grand Rounds will be accessible in person and virtually during Facing Race on November 21st from 2 p.m. to 3:30 p.m. Central Time. Virtual attendance of this session is free. Sign up at www.healthequitygrandrounds.org. Dr. Maybank, a recognized leader in health equity, has spearheaded efforts to integrate health equity principles throughout the American Medical Association since joining in 2019. Previously, she served as founding deputy commissioner for the Center for Health Equity at the New York City Department of Health and Mental Hygiene, where her innovative leadership earned both national and international acclaim. Within the episode, Dr. Maybank articulates her strategy to transform organizational culture at the American Medical Association, advocating for health equity to permeate policymaking and daily operations as a shared collective responsibility. The discussion highlights how the COVID-19 pandemic and the public murder of George Floyd intensified societal awareness of entrenched health disparities and systemic racism within the healthcare system. Dr. Maybank recounts how these crises created a unique inflection point for advancing the American Medical Association's health equity agenda. A key initiative emerging from this period is the Rise to Health Coalition, a comprehensive effort uniting healthcare systems, professional societies, and activists to dismantle inequitable structures. The coalition's early achievements include eliminating discriminatory algorithms in medicine and convening leaders to drive systemic reform. The conversation also addresses the prevalent yet harmful narrative framing health solely as an individual responsibility. Dr. Maybank critiques this narrative for obscuring systemic inequities, such as disparities in access to healthy environments, transportation, and basic health care, which disproportionately affect marginalized populations and people of color. Here's their conversation.
Aletha Maybank, MD, MPH, currently serves as the Chief Health Equity Officer and Senior Vice President for the American Medical Association, AMA, where she focuses on embedding health equity across all the work of AMA and leading its Center for Health Equity. She joined AMA in April 2019 as the association's inaugural Chief Health Equity Officer to launch AMA's Center for Health Equity. Prior to this, Dr. Maybank served as the founding Deputy Commissioner for the Center for Health Equity at the New York City Department of Health and Mental Hygiene. Aimed at strengthening equity efforts and transforming organizational culture, the center became a model of success recognized by New York City leadership, the Centers for Disease Control and Prevention, and the World Health Organization. She was instrumental in infusing equity at the neighborhood level and advancing the department's place-based approach to addressing health inequity. She also set precedents with groundbreaking work at the Office of Minority Health in Suffolk County Department of Health Services while serving as the founding director. Aletha is a highly sought after health expert appearing on national and influential media outlets such as NPR, MSNBC, News One, Roland Martin, The Lancet, and the Journal of the American Medical Association. Due to her leadership in the COVID-19 response efforts, she was interviewed by Oprah Winfrey and authored the New York Times op-ed, The Pandemic's Missing Data, to bring more awareness to the structural inequities in the United States. She moderates the AMA bi-weekly web series, Prioritizing Equity. It elevates the voices and stories of physicians centering equity in the COVID-19 response efforts. Thank you so much, Aletha, for joining us today.
Thanks for having me, Glenn. Good to be here.
I thought maybe we'd start out talking a little bit about your role as Chief Health Equity Officer at the American Medical Association, with your focus on promoting health equity across AMA's work. From your viewpoint, why is that important? And what are some of the approaches that you're leading right now to do this?
Well, I think it's important to, one, realize, so this role actually started before COVID, in actually 2018. The American Medical Association's House of Delegates. So the way that, American medicine kind of works, or organized medicine works, and the American Medical Association, is that it includes representation from across the entirety of the country, structured actually very similarly in the sense of how Congress is structured, and our government has levels: executive, legislative, judicial branches. And so they followed that kind of governance when they created the AMA back in 1847. And it is still considered the organization that has the largest representation of physicians and acts on physicians' behalf. And what is very notable is that it has a particular history, as it's not the only organization that has this, but it's a historically predominantly institution that has experienced racial injustice in its past
Mm-hmm.
in multiple ways. But the one that a lot of folks are more so aware of is its exclusion of Black physicians for almost 100 years, truthfully, from the time that it started to when civil rights legislation was passed. And it was no longer really legal to be able to do that. And so, in order to really move forward and propel this work, I've been part of equity movement for a long time, really learned a lot from you, Glenn, and Julie Nelson, truthfully, on how to do the work within the context of institutions. In 2018, the American Medical Association, the House of Delegates, passed policy. So that's how they decide on what they're going to advocate for, or what they're going to do to start a Center for Health Equity and hire a leader for that center. Now, it's not the beginning of the work that they did as AMA. They did issue an apology in 2006 to Black physicians to apologize for the exclusion. And they also had some coalitions over time. But this was going to be really their first attempt to really have a structural presence within the organization that was going to be solely focused on health equity. And so when the policy passed in 2018, I was hired in 2019. And really one of the first and early, if there might have been one other person before me, identified as a chief health equity officer. That's not to say that many institutions, clearly you've been doing the work inside institutions for many years, but this role becoming chief health equity officer, which is significant, right? It's a chief's title, which means it's within the context of the C-suite. And so the task at hand was facilitate a process to embed equity across the entirety of the American Medical Association. Little small task there.
A little lift.
Little lift. And I really emphasize the facilitate, right? Because as you know, and I know, that this work cannot be the role of one entity within one business unit or department within an institution, but I have to work to find ways to inspire others, also to build accountability structures and infrastructure within the institution. So it's everybody's work, right? And the messaging and communication from that by the CEO, really becomes important around that. So it's not just the work of the center and myself, but it's everybody's work. So that's the role. Also, is building a center for health equity. We do have one of the largest centers for health equity on the medicine side in the country with 16 folks. That's typically it's like 3 to 4 people, truthfully. Still very underinvested or not invested in. I came from public health. I think there was definitely a broader awareness and perspective around, all these larger narratives around health and conditions around health and the importance of equity. It's more, public health is more aligned with the social context and social science of life, right? More so than medicine. Medicine's very much rooted. It's training all of that in the basic and clinical sciences, which is a whole nother thing of history that we have to reconcile with. And so early and important step that I thought that we needed to do was build strategy. That way that everybody could be clear on what a pathway forward is because that, a lot of folks had no clue what's health equity even mean. What are the actions of it, what are the values of it? So really had to lay that forward in a strategic plan that we did release first in 2021. It was 80 pages long, and I always say I've never recommended any strategic plan to be 80 pages long. It shouldn't be. However, it was very clear that everyone was at very different points in just understanding basic concepts. So the first half of it really focused on definitions, concepts, historical underpinnings of how these inequities, were produced and continue to be produced and sustained. And the second piece was more about what are the strategic approaches that we were going to employ at the AMA overall, not just the center. And a piece of that, the first strategy, there were 5 in total. I tend to bring 5 wherever I go. The first is about embedding equity. So what needed to happen internally with the staff? As AMA, they have about 1,200 staff members who work on behalf of the membership of AMA, 270,000 members. So it's a very large, institution in that sense from organized medicine. And so what is it that they have to kind of embody that's going to challenge culture, institutional culture, challenge mental models that have been held that actually can exacerbate, right, or worsen these inequities that exist? And then what are they going to do in order to do something differently? And that's a lot of the work, again, that I really learned from you and Julie, and using the frameworks of the organize, normalize, operationalize. We also added the importance of having trauma-informed systems in order to do that work internally. But another strategy was about building alliances and sharing power, acknowledging that we need to learn from the voices and experiences of those communities and physicians that have been historically marginalized and minoritized, ensuring equity and innovation in healthcare. Innovation is an interesting word. On one level, coming from public health, innovation kind of meant for me the diversity of kind of people, voices, experience at a neighborhood level, thinking about what solution is, designing solution for that neighborhood level. Innovation within healthcare is very much rooted in capitalism. It's kind of how are we creating these ideas, technology that's going to eventually be profitable, and then you sell them and it's venture. And so it's a whole new space that I had to learn. But what's really clear is that there's a lot of injustice in that space. A lot of Black and brown founders are not getting capital support, investment in because people aren't valuing their ideas and who they are. So that has a tremendous impact. And then also we're clear that because a lot of medicine is really focused on the basic and clinical sciences in the context of health, not the social context, not the structural, not the political, that we were going to have to do a lot around educating, providing and developing educational tools for physicians and health systems. And then lastly, the last approach, the fifth one, this part in terms of fostering pathways for truth, reconciliation, and healing for our past. Really, I learned from the Kellogg Foundation when Gail Christopher was there and some of the work that she did. I was at the New York City Department of Health and engaged a lot with them in maternal equity work and birth equity work. This importance of how do we look at our past in very authentic and direct ways, reconcile and then repair that harm and create paths for healing. So that's the overall strategy of how, I've approached the work. And I think if we're going to be any organization that wants to be really committed in its words, has to be committed in its actions. That's the approach that we took.
I have like a dozen questions I want to ask you. We're going to come back to some of them. I think what's really being clear is that this is groundbreaking work within the history of sort of the medical association. It's a big step forward, even if it is a big step.
Right.
And so I'm just sort of curious. We want to come back and talk about narrative, want to come back and talk about structure. But why, in your mind, was this step important for AMA in this period?
Oh, absolutely. I think about why I even accepted the role because folks, I am a National Medical Association member and I was before an AMA member. So National Medical Association was created in the very early 1900s, 19 I think oh 06 or oh 08, sorry if I have the exact year wrong, but around that time, really because again Black physicians were excluded. So National Medical Association I was very familiar with because as students and then Black students in schools, we had strong chapters and organizations within our med schools. So we knew about NMA. And then when I was here in New York, I was actually president of our local and state chapter for New York. So I knew about AMA and honestly, I didn't have, because of the history, much desire to really connect and be in the AMA. And then when this opportunity presented itself, I said, well, there are a couple of things. One, I understood the influence of AMA at the same time, but I also understood, I think I was ready. I could do this work. When I read the job description, I said, oh, I did this. Like, I have this, like, in a very unique way, because a lot of folks haven't done the internal piece of it. I am going to give you kudos again, Glenn, and you and Julie. Like, you all set that foundation, and a lot of folks don't have that, as you know. And so that really created, I think, a unique opportunity for my leadership to know what needs to be done to bring this into an institution. Secondly, it's rooted in policy. So it wasn't going to be, I felt, at the whim of like a particular leader at that time, and then it was going to go away. And, anybody who starts something, and especially in this area, because you don't want to harm people by having something come in and go, you want to ensure that there's going to be some level of sustainability and accountability to that. So it being deeply rooted in policy was also an influential thing from the perspective of medicine. And then during COVID, well, COVID, I'll just say COVID, provided this tremendous opportunity that we didn't think was going to come. And then unfortunately, the public murder of George Floyd also provided this opportunity. COVID exposing inequities, it was in the news. My mother had a sense of what I was doing and the work that I was doing in a way that she hadn't before. First time, like really, and then the evolution and folks talking about racism and naming racism within medicine, where it definitely, we did it in public health. I'm not saying everywhere did, but definitely on the public health front, we did it a lot more. But in medicine, it really wasn't done. So to be able to elevate just that inequities exist, that there's a responsibility and an imperative that medicine, if we value, the betterment of public health and the art and science of medicine, and that means we have to value the opportunity for everyone to achieve optimal health. It was a critical time to really kind of take hold of that, leverage it, and push it forward to me as fast as you can and as far as you can, because sometimes those doors close or that people are going to try to close those doors, right? And then even with naming racism, the med students, and kudos to the young folks. I say this, and you heard me say this across the country in terms of the analysis that they have, the exposures that they've had to allow them to have the analysis that they have, and the courage at that age to really push and drive structural change. They were really some of the great leaders within the AMA to already be ready. They were ready to talk about racism. And because of that, we could be very responsive. And so the board went forward, made a pledge, then we passed policies again on AMA that really created the space that we could do as much as we could within the center over the last 5.5 years. If it weren't for those policies, we would not be doing what we are doing, and we wouldn't have had the influence that we've had, not just with AMA, but the entirety of medicine.
To build a multiracial democracy, Race Forward needs your support. Join us in dismantling structural racism. By texting RFPOD to 44321, you can help us make more episodes about important racial justice conversations. Support by donating $24 in 2024, a pivotal year for our work together. All donations are tax deductible. Again, support our work by texting RFPOD to 44321.
Why do you think the idea that health is a personal responsibility solely is so harmful to Black and Brown communities?
Thanks for this question. I think this is one of those times when I say it's harmful for every community. And that is, the challenge of the narrative of health in this country. Not only is it individual, then people also tend to focus just on the kind of the healthcare system and what happens in the doctor's offices and walls, right? Not this larger context of how we understand who is, especially those who have been in policy and government, where the person lives, access to transportation, wealth, complete determinants in terms of and drivers of what creates health for people within this country. And I think a cause of that also has to do with how medicine has evolved and how physicians have been trained who have kind of the most power in terms of voice, right? Physician community is there is physician supremacy. Like I say that all the time in terms of who is listened to in the healthcare space. And so a lot of the narrative around health happens to be in the healthcare space, not in public health. Folks don't have that understanding. And the Flexner report, as an example of 1910, was when the AMA actually commissioned for there to be a study of med schools. And while there added rigor to most med schools, it also shut down a lot of med schools and really cut out the social context of health and this other structural context of health. The idea that the decisions that we make are in response to whatever our conditions are, our environments, the policies that set up the environments that we work in. And this would play out in patient care. I'm a pediatrician by training. I used to see patients in Far Rockaway in Queens and, in a lower income community, and the parents, well intentioned, loved their kids, wanted to do the best for them. They were morbidly obese, and I would recommend, well, they need to go to physical fitness or physical activity or go to, whatever their local swim places. And they would come back and say, well, that's great, but I don't have money to do that. It's not safe to do that. I can't just have folks and my children rather be outside in the communities that we live because I have to worry about gun violence. So this idea of individual, responsibility alone is just incomplete and it's not even fair. And you're not recognizing all the systems and the structures that actually drive how they're set up. And then a lot of times these systems and structures also exclude and harm the communities that we know have the worst health outcomes in our country.
Absolutely. I want to continue this conversation about narrative, but also just like, what does it mean for us to be trying to impact the way that health is held, thought about, and implemented in the US? And I know you were a central figure in helping to create the Rise to Health Coalition. It works across a health ecosystem, really looking at positional power and how can we make meaningful change and create actions towards a more equitable healthcare system. It's bold, it's sweeping. Can you tell us the story of where that idea of the coalition actually came from and what for you to date you think have been some of its accomplishments?
Absolutely. I think from just like a theory perspective per se, right? It's built on all the principles that you started your work on organizing, right? You organize internally to create change, or you organize externally to create change. And there are intersections and one supports the other or, and both are needed. And so we understand from any time we need to build power and a collective and really drive change, we need to build power. Let me say it that way. And power in terms of numbers, power in terms of impact. What are a bunch of people doing and how can we be more impactful if we bring that all together is really the kind of impetus for the coalition. We really noticed, especially, again, after the public murder of George Floyd and this reckoning that there were lots of folks who were starting to step into this space, whether it's health equity work or anti-racism work. And there were lots of statements being released, but there really lacked, I think, a clear understanding of what are really the values around this. And values are really critical to make sure that we're more aligned, right, as we move forward in our actions and approaches so that we can operate more so in coalition and solidarity. There were just lots of different things. So this was a way to not necessarily fully, reinvent the wheel, because I think it's like how many coalitions also at the same time can people, be a part of. But how do we create space where folks could learn from one another, share with one another, act with one another in order to one, have the confidence, in order to drive change and actually have some, outcomes as we move forward. And I think that in the healthcare space, especially, very important and needed. And so we have a pillar of, payers and health systems, organized medicine, and other professional societies like in nursing and nurse practitioners and all that, right? We have to be operating together. So it's a way to have a, more of a shared vision credit to really IHI, the Institute for Healthcare Improvement, who really came, with us and actually had this idea, I would say probably before us, and asked if we wanted to kind of join them in doing this. And then we asked if you all were interested. And of course, I'm going to be thrilled about that for many different reasons, but also to hold us accountable as folks who are trying to lead racial justice work. I think it was really important to partner with Race Forward, Groundwater, and Policy Institute to do this work. And we launched in May of 2023. In terms of, accomplishments, I'm quite amazed. So that's what, a little over a year. We have more than 20 health systems across the country. And these are large health systems, they're not small. 30 healthcare organizations, again, reaching millions of people. So, millions. 31 pharma biotech research organizations, and then greater than 14,000 individuals have participated. This isn't just sign up, but actual folks who have participated in events, in meetings. And as you know, it takes a lot to organize people, right? A lot of intention and connecting the dots with folks. And so we're starting to really drive some core actions, such as ridding medicine of using racist algorithms by convening professional societies who have been, promoting the use of them for many years, and now getting rid of them because we know they create harm. So it continues to grow.
Historically, I've done work in government, done work at the community level, done a lot of work with systems, like to think I have a pretty good handle on systems. And the medical system is one of the most complex systems easily. As you've been doing this work, I'm sort of just curious, what are some of the things that folks don't understand that you think might help them and us actually move the medical system towards greater equity? You know what I'm saying? What are some of the things that you think folks really just don't understand about how the nature of the system itself?
I think what you just elevated in the way that you framed the question in terms of the complexity of it, but many folks, they're like, but at the technical nature of the healthcare system. That's what I've learned from being at AMA. Now, what's also to that, because I was in public health, I don't think folks realize that there is such a separation between the medical side and the public health side of health. You've experienced that. There's just not great coordination, communication. They operate very differently. And there's a lot of tension between the two. COVID elevated and exposed that we need to figure out and do a better job within the health space. And I say that largely both public health and medicine. Everybody, they each side have their narratives, public health, everything I mentioned before. They have these narratives that are more about who they are as physicians and healthcare providers, and that they have a sense that they're better than us as public health folks. And then I'll hear medicine say, and I've heard this, public health isn't organized, and all types of narratives about each other that does not help them come together. And so we do see some efforts now across the country. Dave Chosky, who was actually a former commissioner at the New York City Department of Health, started the Common, I want to say the Common Coalition. There's another word in there, but this idea and practice and possibility that public health and healthcare can come better together, that works for the people. I think that is a huge gap that folks don't really realize and understand.
I hear you. I do. And I think, one of the things just want to encourage folks is, if you're curious, to go to risetohealth.org and learn about the coalition. Some great work happening. And I actually really do believe that this question of just understanding more fundamentally how systems work, the role of different actors within systems, it's necessary to come up with the right solutions.
I think also for people, I validate, and you do this, we validate how they feel. And I think that's important for, I don't want to use the word patients. All of us experience the context of the health systems, right? We all engage. And I want people to know that their voice and their experience is valid, and that if they bring it up and they elevate it and they are advocating, for themselves or with other people, they are allowed to do that, and they have a right to do that. I think sometimes what people don't know is that, that they do. We see that happen often, and I feel that is part of the work of public health and medicine, right? For us to see the structures that exclude, but also our own personal biases, ways of being, and mental models that also exclude. And I think to the point of what I hear also you saying is intention, right? a lot of people have good intention, right? And I think that's the other thing to recognize. And there are people who don't, but a lot of people within medicine, they do. However, that's not what's ultimately important, right? It's the impact of the decisions that we are making, even with good intention. And what our data shows us for us within health systems, because there are differences that happen in health outcomes, that we are not valuing all people equally. You could say that to your healthcare provider. You are not valuing all people equally, because what does your data show? And that's just real. And it's hard for people and hard for sometimes for the health professionals to digest because they want to know that they're doing good. But the reality is that our systems are not operating optimally for most of us actually in this country.
I heard that, which is actually, it's great. I wanted to come back to the narrative conversation. And I think you're naming a lot of it. Individualism, scarcity mindset, competition, all of those ideas actually are what push inequitable outcomes within the healthcare system. Thinking about your work, your arc of work over the last, decade plus, what do you think?
Makes me sound old.
See, I know. I probably could add a couple years to that, but I won't. What do you think we need to do to challenge narratives? At the end of the day, getting folks to hold that everyone has the right, you named it earlier, Aletha, to thrive, to live in healthy environments, to have quality health care. What is it in those narratives have you found to be helpful in challenging what's been the status quo?
This has been a core part of the work at AMA, again, understanding influence. Narrative is one of the most powerful places, and the oppressors, I'm going to say both, know that, right? That's why we have billionaires who want to control media, right? And want to buy media entities, because if you can control the narrative, you can control how people think, believe, and then in turn act towards one another, but also within the context of systems and structures. And so we knew early on that in order to get to physicians beyond just the strategy that I elevated, that we needed to talk about narrative very explicitly. What is narrative? What drives narrative? How do we create more positive narratives? And what is the language that we actually have to use as well? There's a distinction, right? As you know. And so we released a narrative guide, and again in 2021, and that created lots of attention, lots of positive attention and lots not positive attention. That's where we saw the most organizing. Every single major media entity had an article written by a physician or a healthcare provider that was not for this narrative work. And I believe that is because we really hit at that point of we are challenging the stories and the system that produces these stories, the power that produces these harmful narratives that kind of keep people excluded and keep our hierarchy of human value, whether it's skin color, the hierarchy is skin color or gender or sexual orientation, ability, immigration, all those contexts to how the systems show up. So narrative is absolutely critical to help support physicians understand and see where they are harmful, and then for them to find ways to produce new ones. And I will say, I think we're still I still feel we're in the infancy of doing that within the context of healthcare, truthfully. I think we've done a lot to at least name that they exist. But what's going to fully stick? I think we're challenging the whole entire country for, at this moment in time around that, right? I think that's what we see. It's not just us, it's everybody.
No, it's the truth. And I think, in that way, at the core of it, it's challenging the idea that health and healthcare should be a public good.
Is a public good, right? And a human right. And that's the ultimate thing that I keep going back to now, especially, because the whole movement against DEI, the language of DEI, so diversity, equity, and inclusion, let me spell it out because I actually have a problem with using DEI in general. I just say equity within the context of institutions. I think we get to justice and liberation elsewhere, but within institutions, I'll call it equity. This is not a new activity. The pursuit of equity is not new. I think what many people are learning is that freedom is not given, right, during this time. To see Roe v. Wade reversed is really quite appalling and shocking still. Again, I think in this moment of time, those who have been on this pursuit, our ancestors were on this pursuit. The from the time, the colonizers landed on this land, the indigenous people, our enslaved, ancestors as well. This was their pursuit for freedom. We're a part of that. And we're continuing it on. We've had progress, receipt, some progress. It's the story, it's the American story. And so we're a part of it. We're seeing how it plays out, and we need to continue on that pursuit. That's how I frame it.
I love that. I especially appreciate you lifting up our ancestors and the people whose shoulders we really are standing on today. Doing this work is, at the end of the day, in my mind, about, making America possible, making a just multiracial democracy possible. I have been so impressed by you. I think our listeners can hear it. The work you've done, the energy you bring. I've learned a lot from you, Aletha. And part of that is the fearlessness of doing this work, because pushback comes. And so we're in a moment where that pushback, we're all feeling it, in this election cycle, all the folks who are doing this work across the country. You've been on the forefront of doing this work for years now. Any advice for folks who are engaged, who may be in this moment feeling the challenges of the pushback?
Yes. Well, thanks for the question. One, and thanks for saying you've learned something from me, because I'm honored if you say that, Colette, seriously. And I'd also want to comment that I wouldn't say I'm fearless, right? And I think that's an important human context. I think as folks who are doing this work, we are humans too. We do have fears. We do have sadness. We have joy, and at the same time. And I tell this story about during COVID. Was hard during COVID, definitely for many people, but for healthcare workers, and even for myself, who wasn't practicing but interacting and helping to support healthcare workforce across the country. And I was starting to go to music therapy, so I like art as well, which is an important thing. The context to come back to is in kind of what we're engaging with at the conference at Facing Race. But I went to a music therapist. For me, it was something different. And he said to me as I was in there one time, Aletha, I hear your stories, and I hear you're fighting for freedom and justice, but remember, your ancestors were also fighting for joy. And I need you to go out and find it, And so I bring that in because, one, the therapy part, right, is that we all go through it and we all need therapy. That's my feeling. Every human being does. And then that I have fear in that. I had, the narrative guide, I got death threats, and somebody came to my door and wrote "die B" on it with ITCH, right? And I needed security detail for 6 months. And that's not the worst that people go through, but it was a first for me in that way. And so it's okay to feel the fear. That's the hard part of this work, right? It's exhausting. It's not easy. I think about Ida B. Wells, and we talk about the ancestors' shoulders that were on during that time. I used to say Ida B didn't have security detail. That's what I'd say. As she went to count, like, lynchings, wherever she had to count. And, if she could do it, I can do it, and so I think we have to speak about those moments as leaders doing this, so that we can validate one another, and that we can see one another in the context of doing this work. A lot of my writing has been about that, in New England Journal of Medicine, about heavy expectations, limited protections, and the plight of DEI leaders. I wrote, and I drew a lot of attention, but I just wanted the leaders to be seen, and to know that we're all in this in a very similar way, and that we need folks to be accomplices in this work. We need our colleagues to be accomplices in this work. We cannot do this alone. I've seen so many folks who have my roles leaving the role because it's a lot. I say that as a friend and a colleague to many people leading this kind of work within institutions, especially. And there are a lot of people doing this work in many places. And so that's my advice, do what you have to do for yourself. That's the other thing that I've learned. We're all in our journey of equity, and this pursuit of equity and justice and liberation, in our different ways, in our different times of our lives. And I don't feel it right for people to judge you on where you are. I've had a lot of people judge me for being at the AMA, and I understand a large part of it. So I digest it. And at the same time, that's my choice. And it all is important. It all is important. All these different places and spaces we need to be in order to fight for our freedom, and eventually and our liberation as well. And so people can judge you, but ignore it. You got to do you. And know where you want to be for yourself at that point in your life. You got to choose your journey of justice.
That is such deep truth. You mentioned Facing Race. So it's just around the corner.
Yes, I'm very excited. I'm so excited.
Right? It's Facing Race, which is our biannual conference presented by Race Forward. This year we're in St. Louis. We're expecting 4,000 people.
Amazing.
Many of the folks that we were just talking about, leaders in doing this work from across the country. But one of the things I'm really excited about is that the AMA is hosting the National Health Equity Grand Rounds in lead up to the conference in St. Louis. Can you talk to us about what that partnership with us and AMA, what will that look like as we come away from Facing Race? So like, what are you hoping to come out of this?
Absolutely. So, Grand Rounds, we started in 2023. And, we have partners on board. We have, folks who focus on disability justice, other folks within the healthcare ecosystem who've been doing equity work as our partners. Everything we do kind of in collaboration with others, because we shouldn't be doing this by ourselves, I feel. And this was a way to push the conversation just a step further than kind of the typical ways of talking about health equity, to have different types of sectors a part of the conversation. So not just physicians and not just the medical space, but to have economists and artists. We've had poets be in these conversations to talk about justice and equity and what does it look like. And we don't require that nobody has to say, they don't have to censor their words or whatever. We have to show up how we show up again and speak to this power of intersection. What does solidarity look like? It's interesting. I was challenged recently on solidarity. I've been challenged on this context of solidarity. It's a whole nother conversation, but it's hard to have it if you don't have a root of trust. And that takes time. So I don't want to use solidarity too lightly, to understand that that is needed to get there. However, what we are doing this time is talking about narrative, but at the intersection of arts. I'm a full believer in the power of arts, one as a vehicle, and there's the art of medicine. That's what's also really kind of brilliant about this opportunity, is that our Journal of Ethics in AMA has whole issues on arts and ethics, and actually has been commissioning artists for their artwork on our covers and things of that nature. So the art of medicine has been kind of in full effect already at the AMA, and what does that look like? And so we're kind of bringing that to this conversation. So we have a filmmaker who's a physician. We have the head of Google Health. We have artist Michelle Browder, who's been doing amazing organizing across the country, who has the Mothers of Gynecology, this brilliant piece of sculpture that's like huge in Montgomery, Alabama, who's going to be on the panel. And then we have, in addition to Michelle's an artist, we have Lalu, who is known for his work with Beyonce and all across the country, a Nigerian artist who also, it was a lawyer by training. So he gets structures as well, which is fascinating, and really interested in this intersection of health and arts. And so he's going to be part of it, and he's going to be activating space and have arts demonstrations. So it's really kind of full circle. And then we're engaging and bringing folks within the coalition there. And I think, Glenn, as being a board member as well as Race Forward, going previous years, I would have, attendees come up to me and say, hey, we'd love to see a little bit more health kind of in this space of how we can talk about this intersection of just justice and health in general, but then, this context of arts, because you already had brought arts to the space. We're just adding, to that. So that's, the whole thing. And I think it's going to be fantastic.
I'm genuinely, I'm excited about it. I'm looking forward to it. The great news is that Facing Race is just around the corner, and
Yes.
I will get to see you and spend time with you. But I wanted to say thank you so much for taking the time to join us for the Momentum podcast.
Absolutely.
Thank you for the work you do and have done. And really, I love what you said. Thank you for, doing you.
Absolutely. Well, thanks a lot. I appreciate being here. And again, appreciate your leadership and appreciate being engaged in all that, is Race Forward and Facing Race. So thanks a lot.
Thank you.
Thank you for joining us for this episode of Momentum, a Race Forward podcast. We want to thank Dr. Aletha Maybank for the important conversation. Listen and subscribe to Momentum, a Race Forward podcast on Apple Podcasts and Spotify, and follow Race Forward on social media on Facebook, Instagram, and Twitter/X. Until next time, let's keep the momentum going. One more time for our listeners. We're going to talk about the American Medical Association being a trailblazer sponsor of the upcoming Facing Race 2024 conference that is taking place next week in St. Louis, Missouri. As part of their commitment to advancing health equity through Rise to Health, a national coalition for equity in healthcare, the American Medical Association will bring its National Health Equity Grand Round Series to Facing Race. As mentioned in the episode, the National Health Equity Grand Rounds aims to deepen understanding of health inequities, shape national discourse, and outline strategies to improve the nation's health. The National Health Equity Grand Rounds will be accessible both in person and virtually during Facing Race on November 21st, 2 p.m. to 3:30 p.m. Central Time. Virtual attendance of this session is free. Sign up at www.healthequitygrandrounds.org.